So our next speaker is Professor Ri-cheng. Professor Chen is the director of the Center of Reproductive Medicine, the Ten Shanghai People Hospital of Tangji University in China. Before joining the position, Professor Chen was associated professor with tenure at the Department of Obstetrics and Gynecology at McGill University, Montreal, Canada. Professor Chen was the key person who developed in vitro maturation of human oocytes for clinical application and responsible for cryopreservation of human oocytes produced live birth at the McGill University Health Center in Canada. He published more than 200 research papers and presentations in referred journals and international and regional conferences. Professor Chen edited 3 books and contributed many book chapters. As a guest or invited speakers, Professor Chen delivered numerous lectures in different societies and countries. Professor Chen was former associate editor of the Journal of Human Reproduction, Journal of Assisted Reproduction and Genetics, and editorial board members of several journals. Professor Chen's research interests are focused on the mechanism of oocyte maturation and activation, simplification of infertility treatment, and fertility cryopreservation. Please.
Thank you very much for the nice introduction. And first of all, I would like to thank organizing committee, especially like Professor Milton Leong, and invite me here again. And since the last 21 years, I know him, and he has invited me many times to Hong Kong. It's my great pleasure here again and share my thought about like IVM. Previous and speakers already talked about with oocyte maturation, especially with mechanism, but it's how we using IVM for human infertility treatment. This is my thought, and I think this IVM is not ready to replace human IVF, and maybe we can do some work with IVM, but it's as a supplement, as not as like a full and a replacement for human infertility treatment. That's why it's like my talk is title is a strategy of the mild stimulation cycle IVF combined with IVM, because it's we as supplement and treatment with IVF. My talk is based on this my review. This paper is written. Is published in October issue of Fertility Sterility. And this talk is like a development of the IVM and the technique for clinical and application. So previous speaker already mentioned the follicle size is most important for IVM oocytes development competence. Of course, we retrieve the oocytes, especially immature oocytes, from different size. And you can see here, and different size, we give different name. Of course, it's like for human, where we can get immature oocytes. Normally, we can get is from antral follicle. It's too small, and with transvaginal the guidance, the ovum pickup, it's impossible to aspirate small follicle. That's what we said. It's probably we can get from 4 millimeter in diameter and above. We can get the immature oocytes. Of course, without LH cells, we retrieve the egg. It's always immature oocytes. It's oocytes after LH cells, we can get mature oocytes. Normally, we say LH cells induce in vivo first is oocytes maturation from germinal vesicle breakdown until metaphase 2, just before ovulation. After LH cells, we know by morphology, we have cumulus expansion, ovulation, and after ovulation is luteilization for the spot where I ovulate. How about small follicles? Of course, for leading or dominant follicle, and is ovulation. Per small follicle, normally we consider as follicle atresia, but it's not immediate. And this follicle, small follicle, if we retrieve the small follicle with the timing, we can get some oocytes, is good quality oocytes for IVM. This is a concept, biological concept in the previous 2 speakers already mentioned. Is from GV to metaphase 2 stage. So So after LH cells, especially for human case, as need 24 hours from GV to metaphase 2 stage. But it's today, and we have to give this human IVF is for clinical application, but it's for biological. Previous two speakers already mentioned. It's from germinal-visceral stage. Of course, its first speaker is given different stage, and GV 1, 2, 3 to 7. But it's for clinical application for human IVM. So what's the definition? It's, of course, it's biological. It's from GV stage to metaphase 2. But in my case, it's my thought. I think that even metaphase 1 to metaphase 2 still is considered as IVM. So we retrieve the egg from different size follicle. Sometimes this egg, this follicle already exposed to LH cells. Sometimes not GV stage, maybe just after GVBD. We still can mature these oocytes, but as you may say, this is not a pure IVM. Yes, it's not pure, but it still is an IVM process involved. That's why for clinical application, it's different with very basic biological and concept. Just mentioned is like oocytes aspirate from different follicles. They can spontaneously mature in vitro. Of course, culture condition is affect oocytes maturation rate and oocyte quality. And the second speaker already mentioned is a gap junction, and with Cumulus cell and the oocyte cytoplasm is very important. We know Cumulus and granulosa cell is associated with oocyte quality. That's why I try to prolong the culture, and it's getting good oocytes, especially for cytoplasmic maturation. But it's, my talk is not talking about this mechanism. It's more as a human IVM clinical and the technique and the application. So this is maybe you ask is until today, and of course it's like in my review I already mentioned, is a human IVF technique is developed by IVM oocytes. But as you says today, how many IVM baby is born is probably as 10,000 baby born, healthy baby born. And what's the pregnancy rates with IVM oocytes? As you have different report. Some is like a clinical pregnancy rate with 35 to 50% per embryo transfer. If we see IVF and the technique developed, I just mentioned, it's a human IVF technique. It's based on IVM technique. So initial and like the first IVF baby is born is 1978. It's natural cycle IVF. But natural cycle IVF is not very efficient. That's why and like try to getting more oocytes. And the initial stimulation protocol is mild stimulation. It's combined with clomiphene, and later on it's combined with HMG, try to generate more than one oocytes. So they can like increase efficiency. But it's today's protocol, and you see, and using GnRH and agonist, antagonist, do down regulation, and combine with stimulation with gonadotropin. But it's today we do IVF treatment, we still like have to concede. And using like heavy dose and the gonadotropin stimulation is right thing or not. For example, like our clinic in Shanghai last week is one patient is 23 years old. And somehow we using heavy dose stimulation. We get 77 oocytes. I don't think it's the right thing that we did. Okay, and this is why it made me quite mad. But it's our physician, one clinic, and the one clinician said, oh, this is very successful. I'm getting so many eggs and produce and 28 blastocysts from one stimulation. I think something is wrong, okay? As it's not we need to do. So that's why, and we try to like reconsider what we are doing. We do right things for and the infertility treatment for the women. That's why it's like when I was in Canada at the McGill University and the McGill Reproductive Center, we try to develop and a new concept, a new treatment for the women. And we found a natural cycle combined with IVM is quite efficient. And it's 2004, we produced and one protocol and called Natural Cycle IVF-M. Based on this and result, of course, we did clinical trial. I didn't want to go back, and we did animal model first, and we tried clinical trial, and we get a conclusion and confirmed. It's a maturational and developmental competence of immature oocytes when it's like a dominant follicle is produced. This small follicle we retrieved immature oocytes still is very competent for developmental in vitro and produce and health baby. Based on this, the clinical trial, and we designed one protocol for treatment. Is when woman is come to our clinic, both ovary we do baseline ultrasound scan, and on day 3, and so we found if we found both ovary more than 7 antral follicle, we consider this patient is fit our this protocol. And when this follicle, of course, we don't give any stimulation. It's complete natural cycle. One is leading or dominant follicle reach to 12-40 millimeter in diameter, and the endometrium and thickness reach to 6. And we try to give this a trigger with HCG, because they have leading follicle, they have small follicle. We try to getting this dominant follicle, mature oocytes retrieved. Meantime, we retrieved some immature oocytes. And after a HCG injection, 36 hours, we retrieved egg. And by this protocol, we tried, and this some patients and who is fitting our protocol. You can see here, and it's from leading follicle. You can see left hand picture. You can see first the polar body, and you can see here when you see this we collaborate with the OR and the physician and aspirate leading or dominant follicle first, and you can see the mature oocytes. You can see the first polar body, and the small follicle. You can retrieve some immature oocytes. You can see here they have. And this is germinal vesicle. We can distinguish which one is mature egg, which one is immature egg. And by this result, you can see we have 82 patients and go through this treatment. We have this average age is 35 years old. And you can see here, and from 82 patients, and we get 99 and oocytes, mature oocytes. It means one woman we can get 1.2 mature oocytes plus minus 0.6 immature oocytes. It means it's more than one oocytes collect, and from this woman. And meantime we can collect and 6.8 immature oocytes. You can see we mature them and we fertilize them and we transfer, and these 2.5 embryo we get almost and 35% clinical pregnancy rate. By this result, and we believe, select women with different type this infertility, we can treat with natural cycle IVF combined with IVM. So this is a new approach for infertility treatment. But maybe you ask, how many patients can apply by this protocol? This is a very interesting question. That's why we try to apply this and technique or this protocol. And so it's one of the protocol with my colleague, is Dr. Lim, is from Korea, and it's one IVF center. We try to, using this protocol, we see 1 year, and who is come to like clinic, and how many patients can apply for natural cycle IVF combined with IVM. Of course, we have protocol like says both ovary, and we see and day 3 antral follicle is how many, and based on this and fit this protocol. So we call, and you can see here is one IVF center and 1 year. Of course, not many cases. You can see the patients, and 378 patients in 1 year, one IVF center. It's quite a small center, and did 417 treatment cycle. You can divide the patient. How many patients to fit this IVF, natural cycle IVF combined with IVM, you have almost 37%. So another two group you can see who is like apply for pure IVM. Most likely is PCOS patients because it's no leading follicle and produced during menstrual cycle. The rest is who is like a baseline ultrasound, less than 7 follicle in both ovary. You have to go through controlled ovarian hyperstimulation. So this interestingly, you can see this age, and when is woman younger, you can have more patients is go through natural cycle IVF combined with IVM. Okay, so you can see this over 40 years old, you have a very few patients can do natural cycle IVF combined with IVM. So you can see 3 groups is 1 year and clinical pregnancy rates, no significant different. Okay, so this is a result. Based on this 1 year, 1 clinic, and try, and at least like first and the choice is natural cycle IVF combined with IVM. And we found natural cycle IVFM together with IVM-alone for PCOS patients can treat more than 50% infertile women who is come to clinic with acceptable pregnancy rate and the implantation rate. This is the conclusion. But however, you can see we do natural cycle IVF combined with IVM. May you ask, okay, you transfer more than 1 embryo. One is produced from in vivo matured oocytes. Another maybe from in vitro matured oocytes. Which one implant? You can make sure which one is made woman pregnant. Of course, we didn't know. But as we tried to answer this question, we did a small study. Just compare pregnancy result. When we do natural cycle IVFM, and we can collecting mature egg or without mature egg. This is the result. You can see this is column from A, is both, is mature or immature oocytes is collected at the same time. Is B column is only is the immature oocytes because it's from dominant follicle. Sometimes is a recovery rate is not 100%. Sometimes you can retrieve it, some you cannot. This is we divide these 2 groups, but it's for clinical pregnancy rate is both is no steady different, but is however miscarriage rate is higher without in vivo matured oocytes collected. By this, and we can conclude, clinical pregnancy rate is no different, and the live birth rate when in vivo mature oocytes collected has higher and live birth rate. But I try to promote this program in China, especially in Shanghai, where I'm working, but technically we met is quite difficult because sometimes we can collecting from mature in vivo matured egg from leading or dominant follicle, but it's from small follicle. Our clinician is very hard. So this is why I try to improve or modify our protocol. It means, and we try getting more like dominant follicle, larger follicle. That means, and we try to give like at least 5 days, and at the beginning of the menstrual cycle, we give 5 days clomiphene, maybe 50 to 100 milligram and per day, and for 5 days. So on day 8, the patient is coming again, and we see the follicle, the size. We decide we can give this gonadotropin stimulation or not. Most likely we can give 3 days based on the size on day 8, follicle size. We can give per day 150 international unit per day for 3 days. Once these 3 days are like mild stimulation and occurred, so maybe on like day 11 or day 12, we ask patient coming again. So based on the follicle size, we can like give this HCG for the trigger. So after 36 hours, and we can retrieve and 3 to 5 mature oocytes. Meantime, we can collecting 5 to 8 immature oocytes. Based on patients like endometrial thickness, and we can decide and do fresh embryo transfer, or we can do frozen embryo transfer. So based on this, and we prepare and like a lining. So this is our protocol. But it's like I said, I moved to Shanghai since last year, and we didn't do many cases. But until now, we did more than 100 cases by this protocol, and we have almost a clinical pregnancy rate of 50%. Implantation rate is reached to almost 30%. It's by conclusion, and what I can conclude is mild stimulation. It's not a natural cycle IVF combined with IVM. It's a mild stimulation cycle IVF combined with IVM. Is a quite efficient protocol for women with different type of infertility, especially women younger, under 35 years old. But it's mild stimulation IVF combined with IVM is a, it's not like, how I can say this, it's potential like a first line should be, and one day maybe this can replace and heavy stimulation and the protocol. Okay, and based on this idea, and we have an international society for mild like approach for assisted reproduction. That's why it's also it's our society. We write one paper, one book is published in this year in July. And in the meantime, and we have this ninth like bi-year meeting. So next year is April 12 to 13. We have this meeting, ISMA 2018 in London, and hope like audience can participate in this meeting. Thank you for your attention.